begin?
Yeah.
Okay. Knowledge and hard work together opens the door to opportunity, achievement, success, and wealth. Honorable Chief Guest of the Eve, Dr. Rajesh Shankar Iyer, Consultant Neurologist and Epileptologist, KMCH, Coimbatore. Respected dignitaries, guests, volunteers, and all the participants, a very pleasant evening to you all. I, Hiba, feel extremely privileged to welcome you all to the 81st talk of the Intersociety weekly webinar series, which is jointly organized by the IEEE Kerala section, the Institute of Engineers, Kerala State Center, Computer Society of India, Trivandrum Chapter, Project Management Institute, Kerala Chapter, Internet Society, Trivandrum Chapter, Vakkom Moulavi Foundation Trust, Trivandrum, Life Member Affiliate Group, IEEE Kerala section, IEEE EMBS, Kerala Chapter, and the Institute of Electronics and Telecommunication Engineering. Before beginning the session, I would like to let you all know a few of the program protocols. All the participants are requested to put your Zoom name, same as that of your registered name of the event. And also, except for the speaker, every other participants are requested to mute their audio and video throughout the session. Participants can raise their queries through the chapter, participants can raise their queries through the chat box at any time during the session, which will be later addressed during the question and answer session towards the end of the session by the speaker. Kindly fill in the feedback form, which will be provided at the end of the webinar. And those who require the certificate of the participation may mention it in the feedback form. Now, moving on, I would like to call on Ms. Adulya, student representative of EMBS, for welcoming the gathering.
Ladies and gentlemen, greetings to one and all. Myself, Iwws P from IEEE EMBS Kerala Chapter, is assigned with the task of welcoming all of you who have joined with us for today's talk. It gives me tremendous contentment to be presenting the welcome speech amongst the most esteemed personalities. I extend a warm welcome to all at the 81st talk of Intersociety weekly webinar series. This great venture, initiated by Intersociety, has been successfully coordinated throughout the past 80 talks and is really good going with enormous speakers. Today's talk is not an exception. So today, I find immense pleasure in introducing our speaker, Dr. Rajesh Shankar Iyer, Consultant Neurologist and Epileptologist, KMCH Hospital, KMCH Coimbatore. He will be sharing with us his insights on the curious case of AI and healthcare, a boon or an affliction, a neurologist's perspective. On behalf of all the attendees present here, with utmost honor and privilege, I welcome Dr. Rajesh Shankar Iyer, sir, to the 81st talk of Intersociety weekly webinar series. Welcome you, sir. For introducing our esteemed speaker, we have with us our IEEE EMBS student volunteer, Amina Muhammad. Welcome, Amina, to this session. To deliver the vote of thanks, we have with us Shireen from IEEE. Welcome, Shireen, to the event. I am very delighted to welcome the chair of Intersociety, Harindralal sir, to the evening. Welcome you, sir. Let me also welcome the host of this talk, Ms. Hiba Muhammad Shanawaz. Welcome, Hiba. I would like to welcome all our event organizers and the office bearers to this session. Before we begin the seminar, I would like to express my heartfelt gratitude to all of you who sincerely committed to this event to make it a success. This event would have been impossible without the support of each and everyone present here. So let me welcome all the attendees who are waiting for the session. Let me welcome all of you once again to the 81st talk of Intersociety weekly webinar series. Thank you.
Thank you, Adulya. Now, I would like to invite Ms. Amina of EMBS to introduce our respected speaker.
Hope I'm audible. A warm good evening to one and all present in this virtual gathering. I, Amina, deem it is my privilege to introduce our illustrious speaker, Dr. Rajesh Shankar Iyer. Dr. Rajesh Shankar Iyer is a leading neurologist and epileptologist at Kovai Medical Center and Hospital and PSG Hospitals in Coimbatore, Tamil Nadu. He has over 25 years of experience in the field of medicine and has special expertise in the fields of epilepsy and sleep medicine. He did his MBBS from TD Medical College, Alappuzha, and did his MD in General Medicine from Madurai Medical College. Later, he finished his DN in Neurology from Institute of Neurology in Madras Medical College and DNB in Neurology from Delhi. He also did fellowship in epilepsy and EEG from Sri Chitratirunal Institute, Trivandrum. Dr. Iyer established the first comprehensive epilepsy care center in West Tamil Nadu at Coimbatore in 2011 and has performed 95 epilepsy surgeries so far. He has more than 40 publications in national and international journals to his credit. He got an award for Best Paper on Epilepsy at the annual conference of Indian Academy of Neurology at Cochin in 2009, and is also the recipient of the Best Poster Award at the 12th European Congress on Epileptology. Over the years, he has studied the field of neurology and has now become excellent when it comes to treating his patients. Dr. Iyer is dedicated to providing his patients with the best possible neurological treatment and is committed to delivering world-class neurological care. It is my pleasure and privilege to welcome you to the 81st talk series of the Intersociety weekly webinar series. Once again, wholehearted welcome, sir.
Thank you, Amina. Now, without further delay, I once again welcome Dr. Rajesh Shankar Iyer to begin with the session. Over to you, sir.
Thank you, Amina, for that introduction. Am I audible now? Am I audible?
Yes, sir, you're audible.
I'll share the screen now. Yeah. Is it visible now?
Yes.
Okay. Thank you. At the outset, I'd like to thank the organizers for giving me this opportunity. And as everybody realizes, the topic of artificial intelligence is one of the hot topics, over the past few years. So I'm not an expert in artificial intelligence, and hence my talk will be purely based on the impact of that particular field of artificial intelligence in medicine in general and neurology in particular, and where do we stand as of today. So we consider both the neurologists and artificial intelligence as titans, and we are at crossroads, and what is the future going to be for us is something which we need to discuss at this point of time. So I'll just start off my presentation with a small story. The story is that you can see something at the top, which is a robotic, the floor mopper or something which cleans the floor. And this came in, and my servant lost her job. That's a short story. And you can see what's happening in that cartoon below. I mean, is it time for all the robots to come in and send us out of our work? That's one of the major questions which is coming in nowadays because of the amount of intelligence of this artificial intelligence in various specialties. And are we losing the jobs? And of course, this has been happening in many fields. And because of the intrusion of this, artificial intelligence in the field of medicine, some amount of changes are also happening. So artificial intelligence is not something new. It has been there way back in the early 80s, and we have seen fictions, various movies on artificial intelligence, and day in and day out, when we Google, that itself is an example of our dependence on artificial intelligence to get various information. So far, we have been accepting the artificial intelligence intrusion into our various fields of life, but when it happens in the field of healthcare, where are we today? Are we ready to accept it in total? Are we safe in embracing artificial intelligence?
No, it is not audible, doctor. Dr. Rajesh? Dr. Rajesh, this is not audible. Can you hear me? Hello, Dr. Rajesh? Hello? Hello? Hello?
Hello, sir.
Hello. Am I back now?
Yeah, okay. Yeah. Now you are audible.
Yes, sir.
Okay, thank you.
Very sorry, something happened.
It's okay. That's okay. Go ahead, please.
One second, let me. Sir, I think you have to make me a host, then only I can share.
Nikita, will you please make him the host? You can share, no problem. You can share, sir.
So currently you are the host, but he can share it right now also.
You can share, no problem. You
Okay.
have the permission to do that. Yeah, that's fine. Now it's coming. Yeah.
Is it visible?
Yeah, very much. Thank you very much.
So I think I was not audible from the beginning, no?
No, we have seen the robots removing the cleaners. Yeah.
I mean, I was just talking about the. So this is, I was just telling that we have been accepting this intrusion of intelligence, artificial intelligence in all walks of life. And when it comes to the health sector, where are we today? That is our focus today. So the most important thing between the doctor and the patient is the clinical judgment of the physician, which will decide the patient's clinical outcome, his recovery from the disease. Everything is dependent on the clinical judgment. So that has been the proverbial sword of Damocles hanging over the neurologist's head. So whether this artificial intelligence is kind of capable of replacing the clinical judgment is something which we are looking into right now. So when you do a comparison of the physician and the computer, when it comes to the diagnostic accuracy, there was one study which was published in the Journal of American Medical Association in 2016. In a first direct comparison, it was clearly found that the doctor was more accurate compared to the artificial intelligence in the diagnosis. But then the doctor also made an incorrect diagnosis in 15% of cases. So this is the clinical judgment versus artificial intelligence when you try to compare this particular figure of a funnel where you can see the mouth of the funnel at A. And as you go towards the top part of the funnel, the B and the C. So I'll try to explain what this is all about. So imagine the scenario of a neurologist and the artificial intelligence-based system. Both parties are being called simultaneously to see a patient. And you have a patient who could be a middle-aged man. Either he is having fever for 3-4 days, or this could be a person who is not able to speak. So at the point of the first contact, the artificial intelligence system, it will be having its own camera, microphones, and the various algorithms it will have. But it will struggle to narrow down the possibilities because the first set of possible diagnoses at the beginning will be infinite. So from the infinite set of diagnosis, the artificial intelligence system, that is the mouth of the funnel which I was showing, At that point, the artificial intelligence will struggle to narrow down the possibilities. But with the neurologist who arrives at the scene, he might be able to immediately narrow down the possibilities to a finite number because he has the prior knowledge, he has the intuition, he has the instinct. So as more information become available by the way of leading questions, which we ask to the patient, and we ask for investigations, we look at the results, then the possibilities get narrowed down, it become fewer and fewer. And then a structure will emerge, and we will talk about what's called the differential diagnosis. For example, when somebody comes with a fever, if you don't know what exactly the cause of the fever, will say the most likely possibility. That's called a differential diagnosis, which might include 2 or 3. For example, this patient could be having malaria. That is my first possibility. Second is the typhoid. Third could be COVID-19. Like that, we have narrowed down to 3 possibilities as the cause of fever for this particular patient. So the efficacy of the artificial intelligence system, it will be found wanting to begin with because of the wide possibilities, and it will struggle to come to any reasonable conclusion with a reasonable degree of accuracy. But the efficiency of the artificial intelligence system will progressively improve as you move down the funnel from its wide end towards the tip. We found that the efficacy of the artificial intelligence system will become better and better, and it might even surpass the human reasoning. That is something which we are looking into. Can we use the artificial intelligence system to surpass the human reasoning? That's something I'll talk about later. So as more and more information is successfully fed into the system, the artificial intelligence becomes a better diagnostician, could become a better diagnostician than the human being who is a doctor there. So the clinical scenario cited above can be depicted in the form of a funnel, as I showed in the previous slide. It is a wide diameter representing the reasoning process before the point of the first contact A, and the narrow in the C is the conclusion. So the B in between will be the shrunk part of the funnel, where we have narrowed down the various possibilities as we acquire more and more information. So to understand, I'll again show the picture. As you can see, the wide end of the funnel, where we have not much idea about what exactly is happening. And as we do further investigations, we understand the problem better, and we reach the point B, where we narrow down the possibilities, and at the point C, we have the final answer. So at the point A, the human being is going to be superior to artificial intelligence. But as you move towards the point B, the artificial intelligence system will be acting very fast, and it might reach C faster than human beings. That's the whole concept which I'm going to tell, that as we have more and more, as we narrow down our possibilities, and at one point of time, the artificial intelligence gains space and will be overhauling or will be working faster than the human beings, and it might reach the point C faster than the human beings. So from A to B, the humans might move faster, but from B to C, artificial intelligence will be moving forward faster. So the core knowledge of internal medicine involves, as you know, about 2 million facts, or the data points are more than 2 million. So any artificial intelligence system has to go through at least 2 million facts at the wide end of the funnel, which I showed, before moving forward and reach the point B. So the amount of data which you have to go through is a minimum 2 million. So at the wide end of the funnel, the totality of the world must be encountered with the huge amount of data, which is not possible with the computer logic of you say either true or false, and things will be much more than what you can depict by just saying true or false. So this is one of the most important limiting factor which you should understand of all the AI systems. So the seasoned neurologist, as I mentioned, will quickly move from the world of the facts at point A towards the zone at point B. So the artificial intelligence may, however, be able to outperform the neurologist in moving from point B to point C. That's the conclusion or final diagnosis, due to the limited data points to start with and powerful algorithms with blazing computing speeds. As I mentioned, from B to C, the artificial intelligence is likely to work better. So this is something which the engineer friends will be knowing much better. Anyway, I'm trying to tell some points about the types of artificial intelligence. rule-based expert system versus the machine learning model. So rule-based expert algorithms is something akin to the Google map, where we say that we want to start from one place and reach the other place, and it will show the various options of reaching that particular the destination. So the rule-based systems like the Google map, they are just based on the pre-fed data, what data you are feeding them, and it tends to work in the manner which can be compared to an undergraduate student who is just entered the field of medicine and who is trying to understand medicine. And the undergraduate student try to apply it to new patients and will be struggling to apply it. So it is mainly dependent on static data. For example, we get in the New England Journal of Medicine something called the clinical pathological conferences, and the whole detail of the patients will be given. And we'll be asked to narrow down the possibilities based on the given data. So there, the pattern recognition, and we have to select one key finding in the historical data. That is the most important step for us to generate a differential diagnosis. So that is the one which I mentioned. As you saw, the rule-based expert system. But coming to the machine learning model, which is similar to the the auto driving car system. So it approaches clinical problems similar to a doctor and not the undergraduate student which I mentioned before, who is progressing through the residency by learning rules and patterns from every new patient scene. So the artificial intelligence-based solution is therefore not pre-programmed by humans, but are capable of programming itself when fed with very large amounts of structured and unstructured data. So these data sets are existing in neurology in the form of electronic medical records, including various data of the patients, including the imaging data. So when you talk about the machine model, it keeps on learning from each and every patient, each and every data which you give, and the programming keeps on happening as and when we keep feeding them with the data. So these self-learned patterns are the models which later form the pivot for the artificial intelligence to derive a meaningful clinical inference from a real-time new data. So when you give a new data, from whatever the machine has learned over a lot of data, it will try to apply and come to a conclusion with the new data. So the artificial intelligence thus will be acquiring the dynamic knowledge progressively in real time because of the training and validation which happens with the repeated application of data sets. So this is the most important principle in machine learning techniques, which is superior to the rule-based expert algorithms, which are just static in the knowledge base and output. So this machine learning is particularly useful, and we are also using in scenarios where we use very large data sets like in the electroencephalography, EEG, and in the radiology, the imaging. A lot of data sets are there with the scans and the reports and so in these kind of systems, so the data set is huge. The machine learning is very useful for us. So it is well suited to tasks that require repetitive routine activities such as interpreting scans. So on a given day in a busy hospital, some 100 scans will be reported every day. And if you use a trained algorithm from the artificial intelligence, it might the algorithm might acquire enough process to even outperform the human clinical reasoning skills. So the potential of this particular phenomenon is something which is being exploited for the benefit of the patients as well as for the physicians in the field of neurology in particular. And this potential is profound. So just in a nutshell as to how the machine learning algorithms work, it can either be a supervised learning, unsupervised learning, and reinforcement learning. And the supervised learning means the algorithms perform a complex connect the dots operation between a given set of input data and an associated output. So they are provided with a given set of results, and they have to sort the data to reproduce them. So this is an example where you can see the supervised learning algorithm. We have the training phase and the testing phase. And in the training phase on the left side, the training data is there with the associated labels to create a predictive model. And when tested, the predictive model is shown data that are not labeled. So in this particular example, the apples are being distinguished from the other items. So even when the apple is red or green, when it is an apple, it is recognized as an apple, and the other things, whatever it is, if it is not an apple, they are recognized as not apple. So this is the supervised training algorithm example. So the unsupervised learning means there is a process input information to identify the patterns and associations between the variables, and the output will be is a grouping or summary of the input data rather than a targeted one. So whereas in the supervised, there's a kind of a fixed output. Here, it is not a targeted outcome. So the unsupervised learning algorithms are not provided with a set of results, but they attempt to find patterns and associations within the given data. They make an attempt to find some associations and come out with some reasonable output. So this is an example where the unlabeled input data are processed by the algorithm to see what patterns it identifies. For example, in this case, it can be trained to identify a red fruit. The red fruit can be an apple or it can be a tomato. So the only thing here is they are trained to identify whatever is red. So there's something called the reinforcement learning. This is something which is important because the reinforcement learning algorithms are concerned with producing an action which is dependent upon a given state. So the given state refers to the configuration of inputs or observations from the environment the algorithm is operated in. So they process the given state, and then they decide what action can be taken based on the information given of the state. And they also look into the consequences of that action. And based on the consequences, there is a reinforcement, which can be an award or a penalty, and so that the given state and the action can be paired accordingly. So this is the agent which is performing an action in the environment. As you can see, the action is interpreted into a reward signal and a representation of the state, which are both fed back to the agent. The same action, more or less likely for future scenarios in which a similar state is encountered. So with multiple cycles of the same process, actions can be produced that maximize whatever a rewarding outcome you want and minimize the risk. So the reinforcement learning algorithms learn how best to react to a given state. And the best way to demonstrate this is the chess computers, the reinforcement technique. Using the reinforcement technique, the chess computers were made with the given multiple scenarios or situations will be given to the computer, and what is the best move which can be made for that particular scenario or situation, and whether that move will reward in a win or you will be beaten because you make that move. From that, the reinforcement is given, and based on that, the computer learns again and again and again, so that when you face a particular situation, you know how to make that move so that you reach the reward of winning the game. So it started way back in the 80s, and you know the computer Deep Blue, which was capable of beating Gary Kasparov in 1997. And the Rebel 10 computer defeated Vishwanathan Anand, who was world number 2 at that time, by a score of 5-3. So now the human beings have been badly beaten by artificial intelligence based computers in the field of sports, as you can see here. But that is fine. But when it comes to health, again, I mean, these are all some of the analogies which we can see and understand. But when you try to apply it in medicine, and the things could be different. So, but what is the capability of artificial intelligence? We can easily understand from what happened to the great chess champions when they had to face the chess computers, and they were really beaten by the computers because so much information and so much data is there in the computer about what could be the best move in a given scenario, and the human mind will really struggle to have that many number of moves stored in their brain. It will be extremely difficult. So the computers at that point of time were able to beat the human champions. And coming to the subject per se, which is the artificial intelligence in neurology. And currently, I mean, for the past decade or so, artificial intelligence is being utilized in various aspects in the field of neurology. And I will just sum up what are the exact scenarios in which it is being used. So one is the image classification. So a machine learning algorithm, for example, was trained when they gave a data set of say around 1.3 lakhs retinal images. So when you take a picture of diabetic retinopathy, and then this is diabetic retinopathy, that information is fed to the computer of around 1.3 lakhs of patients or retinal images. And when you tested the new patient's fundus picture again and respect to the computer, it could diagnose diabetic retinopathy with a sensitivity and specificity. Very important terminologies in the field of medicine: sensitivity and specificity of around 90% and 98%. That's a very excellent sensitivity and specificity. And another study in which was published in Lancet, where retrospectively collected data containing around more than 3 lakhs CT scan pictures with the reports in India from 20 centers in India, was used to train and they produced an artificial intelligence algorithm. And then it was tested to detect the critical findings on CT scan. So this algorithm could identify head CT scan abnormalities which was requiring urgent attention. So in a triage process, for example, in a busy casualty, when the patient comes in, the patient is sent to the CT. From there itself, the information will come that this patient requires urgent attention. So the automation of the triage process, triage is one where you separate the patient based on the conditions and based on their needs, maybe into a very urgent, not really urgent kind of classifications we do in the ER, emergency room. But these computers are able to, probably, triage automatically without the help of the doctors. So this semi-supervised learning algorithm to predict conversion of mild cognitive impairment to Alzheimer's dementia. So this is something which is a bit scary actually. When you have some kind of a memory disturbance, which we call it as a mild cognitive impairment, some of these patients who have some minimal memory loss can progress to Alzheimer's disease in the next 2 or 3 years. So when you use MR scans of people with mild cognitive impairment, this computer learning algorithm achieved around 89% sensitivity and 52% specificity in predicting the progression to Alzheimer's based on the images taken between 1 and 3 years before clinical diagnosis. That is, before you make a diagnosis of Alzheimer's disease, when the MRI scan is seen, which was taken 1 year before and even 3 years before, and looking at that itself, 3 years before itself, I mean, the scan which was done 3 years before, looking at those scans itself, we have an algorithm where we can say that you are going for Alzheimer's. It's a bit scary, like somebody who might be looking good and you tell that in 3 years or in 2 years down the line, you become a full-fledged Alzheimer's. But when we use that algorithm, the MR algorithm, it was able to predict that which patients are going to really become demented in the next 1 or 2 years. So the machine learning has the potential to displace the work of radiologists, as neuroimaging converted to digitized image data sets when fed into these algorithms will soon deliver an accuracy which is better than the trained human eye. So the one group of doctors who are facing the heat right now is the radiologists. So the question is, will artificial intelligence replace radiologists? So that's why many of the radiologists are now in a hurry to go into what's called the interventional scenario from routine diagnostic scenario. Many of them are taking up interventional radiology. So will artificial intelligence replace radiologists? I mean, the threat looks really real as of today. So the machine learning will drive changes in healthcare within a few years, specifically in medical disciplines that require more accurate prognostic models like oncology and those based on pattern recognition like radiology and pathology. So oncology, radiology, and pathology are the ones which are, because in radiology we have repeatedly scenarios where we repeatedly read the scans, and pathology where we have repeatedly reading the slides. These are the scenarios where the machines can come in and replace the human beings or help the human beings and try to reach diagnosis faster. So after the image section, I will tell you about the electrophysiology interpretation, especially with regard to the something which I am involved in, that's EEG. So that is one area where it's a data heavy area. For example, we will be admitting patients with repeated fits into our videology room, and the recording will go on for 2 days, 3 days, 4 days, like 5 days, etc. So somebody who underwent the videology for 5 to 7 days will have a huge data for us to sit and read. So imagine how much time it will take for us to go through the data of a 5 days data, 5 into 24, 120 hours data. It will be extremely difficult. So various work has happened in this field to develop algorithms to detect the seizure. That means when the EEG changes, when the fits happens, the machine will pick up that the seizure is happening, and it can mark it in the EEG itself that the seizure happened. So we can go and look at only those marked areas to see the seizures instead of scrutinizing the entire data, which is going to take days or even hours for us to sit and see. So this is, as I told you, this EEG recording is one area where the data is very heavy. And this is one scenario where this artificial intelligence is going to help us, and it is helping us as of today. So there is evidence that a combination of multiple deep learning algorithms could be used to analyze the EEG traces and identify a signature, which will tell us that the brain is going to seize in the next 1 hour. So again, these are the things which are probably, I would say, that already this has been done, and we have machines which can be fit into the skull, which can detect that the seizure is coming and give a shock to the brain and stop it from happening. And this all, I will say, it's the outputs of the artificial intelligence system. So this could have important implications for identifying and mitigating the seizure before it produces symptoms. And another very, very interesting scenario is, are we in a position to talk to people in coma? Because people in coma, what is happening in their mind? Nobody knows, including the physician, including the people who are dealing with people in coma. We do not know what is happening. So there are some work going in this area where, in addition to the recording and classification of the inputs from the patient, which includes EEG, which includes various other data, and there is development of the brain-machine interface. So this will one day probably give us the opportunity to communicate with people in coma. So what has been remaining as so far as fiction in movies is likely to come true because of the amount of advance which science is making. Probably, I would say, with the help of artificial intelligence, we'll be one day talking to people in coma. So what are the future areas in addition to what I mentioned, the image and the electrophysiological identification? The future areas is, again, it can be in the diagnosis where any data with a lot of videos, it can stratify and say what exactly it is. If you pre-feed the machine about the various type of abnormal events and the diagnosis, it will be able to tell you what it is. The image classification, again, various syndromic diagnosis for us. The genetic applications are there where it can predict some variants which are going to cause rare genetic disorders. And also, it can help us in predicting the complex disorders. Complex polygenic means it's not based on one single gene. Various factors could be there in the occurrence of Parkinson's disease. So all the factors can be analyzed, and we might be able to predict that this particular person might develop Parkinson's in future. It may not be a good thing for us to know, but those kind of things might become available in future. And also in epidemiology, where you detect signatures of early disease in large population-based data sets. For example, we have the UK Biobank. And also in the management, wherein we can predict the response to therapeutics. So to date, the development of machine learning algorithms has mainly focused on training them to reproduce diagnoses that are made by humans. If they are to achieve a performance surpassing that of humans, the data used to train algorithms would have to change. And as I was talking in the beginning, the suprahuman performance could be one day achieved, because especially if the inputs which we give to an algorithm are paired to an output that we cannot predict. For example, if we try to match a CT image to a biopsy result, we might be in for some interesting findings where the machines might be telling us something which we never imagined. So that's a suprahuman performance would sometimes be achievable in future, and people are working on that. So limitations of machine learning is something which you should know at this juncture in this field of medicine is junk in, junk out. So if you give junk as the input data, then the junk will only come out as the data. So without the sufficient volume of high quality training data, even the most state-of-the-art algorithms are doomed to fail. The second important thing is the bias and generalizability, because the insufficiently diverse data if you give. For example, in this picture which I show, where only the apples which are red are being shown, then in that situation, it can misclassify, as you can see, the tomatoes which are red as apples. So the diverse training data, diverse data should be there. Otherwise, there will be a lot of mistakes as happened in this particular slide can happen. So a model which you develop in an emergency department may not have the same performance characteristics in an outpatient clinic. And another one is the bank, UK Biobank, for example, may not represent the sampling population, and it may be overrepresented by the whites and more the socioeconomically advanced groups. So there could be some bias in the data, or the various banks which we have. There could be a bias there. So you have to be very careful when you try to generalize those findings into the general population. Then the performance versus safety. So compare two scenarios where the human eye or the doctor is having a 96% accuracy, whereas the artificial intelligence is having 99% accuracy. So you will go behind the 99% accuracy. But what if the 1% incorrect the inaccuracy in the algorithm is a fatal one? For example, if instead of cutting one small structure, it might cut an artery, and the patient, the robo might cut an artery, and the patient may die. So that's happening only 1%. But when with the humans, the particular problem could be 4%, but it could have an implication for clinical safety. So the problem here is we cannot go by percentages here, because the artificial intelligence, if it makes mistakes, those mistakes could be very fatal sometimes. For example, the healthy individuals can be classified as having a disease and might be subjected to some risky interventions, and diseased individuals can be misclassified as healthy and may be denied potentially helpful treatments. And this concept of black box, is that when we know the input to an algorithm and we know the output it produces, but we don't know how a particular output was arrived at. We have absolutely no idea in those scenarios how the output, the solution was arrived at. That's called the black box problem of machine learning. So the underlying rationale for the generated output by the artificial intelligence algorithm is not scrutable, not only by the physicians, but it's not, you cannot scrutinize that. But also that the engineers who developed them, they also cannot scrutinize how it happened. Another most important drawback is the accountability. Suppose you develop some ethical and legal issues, and whom are you going to hold accountable? So that is a very important issue in this scenarios. And I think in the previous talks, somebody was discussing about the ethical aspects of artificial intelligence. When something goes wrong in the field of medicine, whom are you going to blame? Is it the person who wrote the code for that particular intelligence? Is it the engineer who incorporated into that device? Are you going to blame the scientist who chose to apply it in a certain way? Or are you going to blame the regulator who approved that particular methodology of treatment? Or finally, as we all know, the clinicians will be blamed for everything. So are you going to blame us, the clinician who oversaw its use? So it's a big question. So whom are you going to blame when you put the entire, when you are going to depend too much on the artificial intelligence? The question of accountability is there. So there are some unintended consequences of machine learning in medicine. One is a de-skilling, that is reducing the skills of physicians, which is unavoidable. So I will demonstrate this by an example wherein you would have seen the ECG strips. And there was a study when the ECG strips are given to physicians. There on top right of the ECG strip, the computer-assisted annotations or diagnosis will be there. So they deliberately give wrong diagnosis in many ECGs. So when they did that and asked, the physician did not know that such a thing had happened, the diagnostic accuracy dropped almost 10%, from 57 to 48% when the ECGs were annotated with inaccurate computer-aided diagnosis. So when the artificial intelligence comes in and makes some mistakes, when they try to support the physicians, the physicians might depend too much on the machines, and their skills might go down and they might make more mistakes. So that is one unintended consequence of machine learning in medicine. And you might focus too much on the text, and the context might be lost. So when we deal with patients, it's not only some tests, or it's not an object which is sitting in front of us. It's a human being in flesh and blood which is sitting in front. So we might have an additional element of psychological issues. We might have an element of social issues and social responsibilities, and various other problems. We might be somebody who is related to somebody, who might be having some organizational issues. And one needs to look into all these aspects before we make a diagnosis and a treatment. And the machine is likely to fail in these scenarios where it is called for to make a diagnosis or a treatment for the patient. So there will be too much focus on the text, and the context in which the patient is appearing in front of you might be lost. And there is something called the intrinsic uncertainty in medicine. That means the medical observations and interpretations that are the input to the machine, that uncertainty, when you give an input to the machine, the intrinsic uncertainty is not usually considered. So the extent that the reliability and accuracy of machine learning performance is affected by the observed variability. For example, the same scan, when you give to 3 or 4 radiologists, definitely there could be a lot of observer variability. And also the same patient, as you all would have experienced, when you meet the same doctors or the same specialty with the same problem, the solutions could be different, solutions offered by the doctors could be different. So this observed variability is never considered in artificial intelligence, or it is underrated in artificial intelligence. And the next important thing is the need to open the machine learning black box. So the nature of the machine learning algorithms, which, as I mentioned, we don't know how the output is reached. So the black box models, the rationale for the output is generated is inscrutable by the physicians as well as by the engineers who develop them. So I hope that I have touched upon the intrusion of artificial intelligence, which has already happened and is happening at this point of time. And we have been asked to pass our judgment, whether this intrusion is a boon, or is it a kind of an intrusion which causes a lot of confusion, and is it some kind of an intrusion which is going to kind of affect the doctor-patient relationship? It is a big question which is in front of us. So there is still a silver lining, is that such systems are not complex enough to completely replace a human being. I'm sure none of you will be ready to go and get a surgery done by the machine. And you say that you want to get the surgery done by a robot, not by a human being. And as of today, none of us will be ready to fly in a flight which is not having the pilots and only the machines are there. But the situations are likely to come in future. So there are situations where the cost of making mistakes is high. So for example, when an artificial intelligence model performs surgery and kills the patient, or we have the auto drive mode vehicle and it makes a mistake and you meet with an accident that's risky. So these mistakes can lead to loss of human life. And when it comes to the other scenarios which I was mentioning, where the artificial intelligence is being used, the mistakes are less and the mistakes are not of such a magnitude that the human life is affected. So when you're dealing with the human life, in the medical field, only these kind of questions are emerging and we are searching for an answer. So to quote Charles Darwin, it's not the strongest of the species that survive. It is neither the most intelligent of them which are going to survive, but the most important one is the person or the species which are ready to change. The one which is most responsive to change are the ones which are going to survive. Not the intelligent one, not the strongest one, but the one which is looking forward to change. So in that context, I would say that we physicians or neurologists are looking forward and welcoming artificial intelligence into our fold to improve our care of the patient. So as of today, I am not in a position to say that they are going to replace us. They are probably going to help us in a big way in which our patient care is going to become better. But you can see that because of the usage of artificial intelligence in the field of radiology, oncology, and pathology, as I showed in the first, the opening slide, are the radiologists being pushed out of their work by the machines. So as I mentioned, when the machine for cleaning the floor came in, my servant was sent out. So these kind of situations are happening. So will that happen for the entire group of doctors in the future? One can never say. But as of today, it may not be something which is happening, but one can never say. But we have to be responsive to change, and the changes in the next decade or so is going to be big. We are going to see a lot of machines, a lot of computers when you enter the hospitals, and maybe less number of human beings. The hospital scenario is going to change. And even now, if you see most of the medical record section, most of the laboratory sections, the number of the human hands have come down in many hospitals. The algorithms of tomorrow may equal or outperform the doctor, even at the wide end of the funnel, as I showed in the beginning. The wider end of the funnel, where the options are too many, where the artificial intelligence really struggles to figure out what's happening, and the tomorrow's algorithms might even outperform the doctor at the point A itself. So probably those days are not far away. We might see that particular scenario. So are we ready for that is the question. So there is a need to create awareness and foresee this disruption while going along. So the disruption is something which I mentioned about the various side effects of artificial intelligence, either intended, which I mentioned 4 or 5, or the unintended ones which can really happen, where it really affects the clinical capability of the human beings. We need to be aware of this, and we have to foresee this disruption which can happen, as well as the intrusion of the artificial intelligence in our day-to-day practice. And we have to definitely adapt to this new reality of more and more artificiality or artificial intelligence coming into our practice. So as William Osler once said, medicine is the science of uncertainty. Everybody knows that. And it's the art of probability. So what we should do in this scenario, you listen, they say, listen to the patient. Because if you fail to listen, the patient is telling you the diagnosis. As of today, we understand that the artificial intelligence is all ears. It's listening. But are we the physicians, are we the doctors listening enough? I think we should start listening. We should see the important role of artificial intelligence in making our care of the patient better, and adopt the various changes so that ultimately the patient benefits. So coming back to the question of is it a boon or a bane? Is it a boon or an intrusion? I would say that it is probably a boon as of today, because it is helping us in decreasing our burden when you handle the patients. So, and I hope that it remains a boon also in future if it is properly used, and the ultimate aim of the patient care is kept in one's mind. I hope that this artificial intelligence intrusion into the field of medicine in general and the field of neurology in particular remains a boon. And thank you all for the patient listening.
Thank you so much, sir, for that wonderful session. It was great listening to you. Now, we have already received some queries regarding the session. And if any of you have more further queries, do post them in the chat box. So, sir, it will be very kind of you if you could respond to those. Shall I read them to you, sir?
Yes.
Okay. Is there any permanent solution to stop fourth seizure happening to human brain?
Yeah, that I think is probably. What is this? Am I audible?
Yes, sir, you're audible.
Yes, yeah.
Yeah, that is probably not related to artificial intelligence, but seizures in many situations we are able to control them, either by medicines in 70% of the situations, and maybe in the remaining 30, where we call them as a drug-resistant epilepsy, or patients who keep getting seizures despite all the efforts we put in terms of medicines. We call them drug-resistant epilepsy patients. For them, surgery is available. So a sizable number of patients are currently seizure-free or fit-free, either with medicines or with medicines and surgery, and some of them are off medicines also. So only some 10 to 20% of the patients are unfortunate that they keep getting the events seizures despite all the medicines.
Okay, sir. Moving on to the next question. In industry and electrical substations, we use programmable logic controller integrating small controls, and it is so advanced that substations are mostly automated.
You're not audible. You're not
that
audible.
An operator can get an alarm in his office. There is a hazard developing in inventions in the future.
You're not audible. Can you summarize the question for me?
Hello, am I audible, sir?
Yeah, tell me.
Okay. So
Just
next
summarize it.
question is, in industry. Oh, okay.
Yeah.
Will telemedicine be working on in future inventions by observing a patient from far distance? That's
Yeah, I mean, see, without proper examination of the patient and observing the patient, see, in neurology, there are some disorders where as the patient walks into the room, you might be able to make a diagnosis, for example, of Parkinson's disease. But probably that is not our ultimate aim. We have to see the patient in toto, and you have to look into the way. That's the wide end of the funnel I was talking about. Unless you make it very clear examination and pick up all the findings, you will not know what exactly are the problems. It may not be a single problem. A patient with Parkinson's disease may have anemia. A patient with Parkinson's disease who walks in and you make a diagnosis of Parkinson's, you may not be treating him immediately for Parkinson's because you'll have diabetes. You'll have a urinary infection for which you would have come in. You might not have come in for the Parkinson's disease. That's why I'm telling you that the possibilities at the wide end of the funnel is too much for any machine to kind of reproduce it. So it's not probably the right method of making diagnosis by seeing patient at a distance.
Okay, sir. Our next query is based on increasing usage of artificial intelligence in the medical field, what is the change brought into medical education to better leverage in the...
I mean, the audibility is dropping. Can I answer it like it's artificial intelligence in medical education? Hello? Am I audible?
Yes, you're audible.
So I take that question as probable artificial intelligence in medical education.
Technological advantage. Is there any move by DME to upskill the medical fraternity statistics, etc.?
Yeah, I don't think in the current medical teaching syllabus we have much about this the science part of it. So we have been reaping the benefits of the hard work put in by the engineers and scientists. But for example, the questions are raised by the physicians because we reach a situation where we need something to pick up some, for example, when you take the radiological scans for an acute stroke, a stroke which happens within the first 1 hour, 2 hours, how to identify it. The CT scan will not show anything. So when that question was raised, one particular mode in the MRI called the diffusion weighted was invented by the scientists or the engineers, which helped us in picking up the stroke at the earliest part. Like we interact with the scientists to and raise our requirements so that they come out with new technologies. So how it is being done and the technological part of it, as my understanding is that it's not at all incorporated in our current medicine syllabus. Hello?
Hello, sir. The next query is, as artificial intelligence can and do listen better than now doctors, and holistic evaluation also be do better than artificial intelligence in future. How far in the future do you see that possibility?
Possibility of artificial intelligence overshadowing the doctors in the initial evaluation.
Yes, sir.
So the possibility as of now, I feel, is that when you look into the patient, there are two ways of analyzing them initially when they come to meet you. One will be the clinical evaluation, the other one will be the investigation evaluation. So the investigations can be either blood, urine, then the scans and all. So these things could be easily interpreted by the artificial intelligence. But when you consider the clinical evaluation, as of now, I don't foresee the robo welcoming the patient and doing an examination, or robo sitting in the OPD room and seeing the patient. That scenario looks a bit far off. But of course, the imaging part, the laboratory part of it, I think the artificial intelligence can easily take over and give us a final report of what all are wrong with the particular patient.
Okay, so our last query is there any portable artificial intelligence-based device available in the market for self-diagnosing gradual memory loss?
There is no device such available, and even those scenarios which I mentioned before, like the MRI being used as a tool, the volume of brain, the volume keeps decreasing as you age. So what is the volume of your brain for the particular age? If it is less than a particular level, then you stand a chance of developing Alzheimer's. So how much is your chance as you grow older? We can probably gauge. But again, this is a lot of the ethical aspects of that. Is that when you tell somebody that you might develop Alzheimer's, you may be wrong also. So it's not properly. It's not something which is being utilized now to kind of predict people who can develop Alzheimer's or can develop Parkinson's disease, because the diagnosis of these disorders are not welcomed very easily by the patients, and especially if they have the disease, even at that point of time, it's very difficult to accept that you have a disorder. But if you are going to predict that you are going to develop it, then that is something which is probably will have a lot of ethical backlashes. So as of now, we don't have any technology available in the market which you can use to find out whether you will develop Alzheimer's or not.
Thank you so much, sir, for sharing all the queries out there. Now, Jacob, EMBS member, to deliver the word of thanks.
Good evening, all. Am I audible?
Yes, go ahead.
Okay. It's my privilege to have been asked to deliver the vote of thanks on this occasion. Now, on behalf of IEEE Kerala session and Intersociety weekly webinar series, I extend a very hearty thanks to the Honorable Speaker of the Day, Dr. Rajesh Shankar Iyer, who gave an excellent session about AI role in healthcare. Now, let me extend my gratitude towards Mr. A.G. Harindralal, who plays a key role in making IWWS talks a successful till the date. I would also like to thank Ms. Hiba Mohammad Shanawaz for being the moderator, and also Ms. Atulya and Ms. Amina Mohammed for the great participation for the session. Also, I express my gratitude toward Ms. Nikita Sajid for active volunteering in the smooth conduction of the program. Last but not the least, I would like to thank dear delegates and participants without whom the program would have been incomplete, and for your kind listening and patience throughout the session and sharing your views and opinions and making the session a success. Once again, thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you all. Thank you, sir.
Now, as I showed you, we have today's session successfully.
Thank you, sir. Thank you all.
I would like to announce the next section in IEEE. Thank you, sir. Now, we will have
Hello.
a second talk at Advanced Systems starting from 6 p.m. to 7 p.m. Hello.
Yeah, we have our 80-second talk on engineering strategic systems for Atman Parza by Mullavi R of Tata Advanced Systems next Wednesday. Sorry, the date is wrong.
The date is wrong.
Yeah, the date is wrong. It is, I think, the 2nd November.
3rd November.
3rd November. Sorry for that. 3rd November. And all are requested to attend, please. Thank you very much. Dr. Rajesh, thank you very much for your great presentation. A lot of information were given. Thank you for a very valuable presentation. Thank you very much.
Thank you.
Nikita, you may close the the PPT.
Okay, sir. You're the host right now, so you can end the meeting.
Yeah.
Is Dr. Rajesh available?
I think he left.
He left already. Okay.
Okay. Thank you all. Thank you all for the participation.
Thank you.
Yeah. Hoping to see you the next week.
Okay.
Thank you very much. Have a great day.
Okay.
Nikita, you may close the session.